another video at the Tooth Factory. We're going to continue our dental pharmacology series with our latest opioids lecture, the Analgesics Part 2 for AFK and INBDE edition. It's created by Dr. Kanan Shah and presented by me, Dr. Rishi Shah. So normally we know opioids as drugs, right? Some things that have needles and pills and cause pain-free effects. That's exactly what we're going to talk about. However, let's talk about it in a dental pharmacology perspective. In table of contents today, we got analgesic classification for opioids. Then we'll discuss the pharmacology, therapeutic uses, contraindications, adverse effects, and then we'll discuss various opioid analgesics one by one, and then end with analgesic doses and references. For references, the links are placed in the description box below for the two textbooks that we used to create this lecture. Please feel free to open them, they're free access, and if you have any questions for the lecture, do not hesitate to ask us. Little fun fact for us to warm up the lecture today is this flower is called opium, and as we could tell, opium creates what we call opioids, primarily grown in Afghanistan, by the way. Let's take a look at the opioid analgesic classification. There are four major categories that we'd like to discuss. Right, we got opioid alkaloids, we got synthetic narcotics, we got synthetic derivatives, and then methadones. So consider opium alkaloids as natural, right, completely grown by nature, and synthetic narcotics completely grown in lab. Just a way to remember. Synthetic derivatives are basically of the natural. They're synthetic, but they're derivatives of the natural. And then methadone is on its own, and we'll discuss these drugs in fair detail in the coming slides. So as an overview, in the natural aspects, the opium alkaloids, we have a strong agonist and a weak agonist. In strong, we have morphine, the mother of all opioids, and then codeine. Synthetic derivatives and synthetic narcotics sound very similar, right? But again, synthetic derivatives are part of natural, because they're from morphines and they're from codeines. It's their families. So let's meet the children of morphines. As the parents, it's got strong agonist qualities, and they're known as hydromorphone and oxymorphone. These are the siblings. Then there is a mixed agonist and antagonist called NALBUPHINE and codeines. The codeine family has also hydrocodone and oxycodone. These are the siblings of the codeine family. Now, moving on to synthetic narcotics themselves. Again, we have strong agonists and complete antagonists. In strong agonist, we have meperidine, fentanyl, and the children of fentanyl such as alfentanil and sufentanil. Antagonists, we got naloxone. And then methadones, we have a strong agonist called methadone themselves. And then mixed agonists and antagonists, we got PROPOXYPHENE. I know these names may be confusing at once, but if you consider them as the stories that we just discussed, you might just have an easier way to remember them. Okay, let's take a look at the opioid pharmacology. Now the words that are about to pop up might be a little confusing, but let's try and make them sound very simple. See, first of all, we need to know that whatever happens has to do with central nervous system, right? We got a presynaptic membrane that then goes to neurotransmitters which attach to receptors and then activating no pain feeling. This is what opioid does essentially, right? But just a little bit more detail. G protein linked receptors. All the opioid receptors that we discuss have a quality of being G protein linked receptors. They end up decreasing the neurotransmitter release. See, these neurotransmitters that are in the synaptic membrane are going to go and attach to these receptors and cause pain. But with our opioids help, when they attach to the receptors, they in turn decrease the release of these neurotransmitters. Therefore, low pain, right? Low pain initially. No stimulation. Therefore, they decrease the primary afferent terminal in the spinal cord at the presynaptic neuron. This statement means that there will be less sensory effect at the presynaptic neuron. and therefore it will increase the postsynaptic potential. What does this statement mean? Well, this is the threshold required by the postsynaptic membrane right here in order to cause pain. But because of the opioids actions, this potential goes up. The threshold goes up. Therefore, now we need more and more neurotransmitters to cause pain. So look how opioid is working. It is causing a decrease in neurotransmitter release that cause pain, and then it'll also increase the threshold of the receptors on the postsynaptic membrane, which then increases the pain threshold. Therefore, you need more neurotransmitters. So it's blocking the ends in both ways, and it's an effective pain inhibitor. In other words, it causes inhibition of the midbrain, and essentially, in summary, it's called a CNS depression. I hope the pharmacology was a little simple and the stories are well told. Let's take a look at the receptors that our body has on which opioids really act. We got a mu, a kappa, and a delta, each with their own function. A mu receptor is located supraspinally, causing analgesia. Kappa is in the spinal, leading to analgesia. And delta has an antagonistic activity. Now this is just for information. We're not going to be using the delta receptors in today's lectures at all. We also have endogenous opioids, which means opioids that are produced by our body naturally. We got enkephalins, endorphins, and dysnorphins. Most of us have heard endorphins, right? They cause the pain-free feeling in the brain and euphoric nature and all happy-go-dilly feeling in our brain, right? That's endorphins. Such as when we have exercises, our bodies release endorphins and we feel good. Enkephalins are associated with more than just pain. We got perception that is blocked, we got movement blocked, mood altered, behavior altered, and that's what enkephalin has to do with. So every time you're angry, blame the enkephalins, not the person ahead of you. I know, a very bad joke, guys. Let's move on. And then comes the dynorphins. Dynorphins are associated with the cardiac system regulation. Cardiac system regulation and today's lecture are far away, so we're not going to talk about these. Opioids therapeutic effect. Yes, the opioids, I understand that they are in the CNS, but they cause effects all over the body. Let's take a look at how. Biggest effect of them all, and therapeutic means, is increasing pain threshold. Our goal is to have analgesia. So first of all, it increases the pain threshold, which means if you were stabbed by a little needle, you would have received pain within a fraction of a second. But if you are on opioids and then you got stabbed with a needle, it would need 3 or 4 needles to cause you the pain, and also longer duration before you feel the pain. That is what this statement means. And then alters the pain reaction, so you don't really scream, you just feel the pain. No ceiling effect, which means it just keeps going until it depresses your central nervous system completely. There is no cap on it. We have to cap it by dosages that we will talk about. And here it is. Limit the dose by side effects. Basically, if the side effects begin to occur, that's where we stop taking that dose of opioids. These are the therapeutic effects. But let's take a look at what the effects of opioids are on your body. Right? What does the drug do to your body? What's the pharmacodynamics? Over here we realize that on the bloodstream, it causes heroin or crushed pill injections that lead to veins to collapse, like literally collapse capillaries, right? On the heart lining can become infected due to the contamination from the needles and the pills itself. And several other effects on the body, such as we got brain, where it can lead to sedation and depression. On the lungs, it can cause respiratory depression and so on and forth. Digestive system, it can lead to constipation. In the liver, it can lead to hepatitis. In the nervous system, in the body throughout and extremities, it can lead to sensitivity to pain being greater only when there's opioid abuse. So too much use can actually lead to excessive pain. On the immune system, we are more susceptible to infections, due to the reduced immune response. Now, these are just a little overview of what opioids can do to our body. Continuing with therapeutic effects, or therapeutic uses this time, we're going to talk about when to use opioids. First of all, for acute analgesia, when we need pain relief right away, immediately. For treatment of myocardial infarction, this has to do with severe amount of pain, right? This myocardial infarction is what they call is doomsday worthy pain. And then treatment of acute trauma and obstetrics, this is during labor. Chronic pain relief for cancer and neuropathic aches, again, chronic pain, excessive pain. And then preoperative sedation. So when we intubate patients, or we need sedation given to the patients, but the patient is very anxious, we give them opioids, such instances. Epidural anesthesia, then pre-anesthetic medication, similar concept. Antidiarrheal medication. Remember, in the previous slide, we just talked about one of the effects on the digestive system is constipation. So constipation is actually a treatment measure for diarrhea. So it causes antidiarrhea. And then antitussive medication. Remember, on the lungs, it was a depression of the respiratory system. Therefore, antitussive. Antitussive is coughing. Coughing. So it reduces coughing. Remember our childhood cough syrup, Benadryl? Well, that has codeine. Detoxification of opioids. Now, before I read this statement, I want you to know these are therapeutic effects. Sometimes we need to use opioids to kill the effects of opioids. So here it is. Detoxification of opioids during addiction and dependence. We use methadone. And in the treatment of opioid overdose, we use naloxone. Now, the best way to remember these two drugs is addiction, methadone. Overdose, naloxone. Just a little tip so we remember methadone and naloxone and their functions. Very important for the exam, guys. Now let's take a look at the physiologic effects of opioids. Now these are no longer therapeutic effects. This is what actually happens to our body. Opioid analgesia, very simple. We know it kills pain. What about sedation? Well, opioids will have increased with other depressants. So if you use opioids with, for example, benzos together, it will lead to increased depression in terms of your CNS. Alcohol, we need to be cautious to use with opioids. Ideally, we shouldn't be using them. And then caution in ambulatory patients. In the mood alterations, there are two ways we can go. We can go euphoria, which is mental cloudiness. We just feel happy and just confused. Well, dysphoria, it is completely unpleasant. So euphoria is heaven and dysphoria is hell. Imagine that. Terrible, very good. It can lead to both. Now, in the GI effects, the gastrointestinal tract, we know that there is going to be a decreased peristaltic contractions. So less movement of bowel. Guess what that leads to, guys? Yes, the one and only constipation at consistent use, of course, not just one use. But it can treat diarrhea. Remember, guys? Diarrhea. In respiratory depression, again, we're coming back to this. Decreased CO2 stimulated ventilation. Right? That is the most serious side effect of opioids. Now, why is it in red? Well, because I really want to talk about this little tiny concept in 2 lines. Our breathing is not stimulated by oxygen. Yes, I know I said oxygen and not stimulated together. Bear with me. Our breathing is actually stimulated by a CO2 level in our blood. When there is an increased CO2 level, our body is bound to get rid of them, causing exhale. And in exchange, we get O2 coming in. But remember, when there is CO2 blood levels in blood, that causes the stimulation of breathing. So, if opioids are used, this doesn't exist, leading to no breathing. In essence, it is respiratory depression. One of the worst effects of opioids. Moving on, the nausea vomiting concept. Okay guys, let's get your pens and papers out. This chart will help us understand how opioids can cause nausea, vomiting, and how they can prevent it at the same time. So in our body, we have the CTZ, the chemoreceptor trigger zone. Right next to it, physically next to it, there's the vomit center. At low doses of opioids, we activate the mu receptors. The supraspinal, right? Mu are supraspinal in the brain. We activate them. That leads to stimulation of the CTZ, the chemoreceptor trigger zone. That then stimulates the vomit center and causing vomiting. So that's how we can cause vomit by low doses of opioids. So very important here, low doses of opioids causes vomiting and nausea. However, in high doses, we activate the deep medullary receptors that lead to the inhibition of a vomit center directly, not through the CTZ, but direct inhibition of vomiting. So at high doses, the opioids lead to inhibition of vomiting. Here are just other examples of receptors in our body, like receptors with their own neurotransmitters and molecules. We got dopamine 2, serotonin, histamine, and muscarinic. These, when blocked, will lead to the inhibition of the CTZ. Now, when CTZ is inhibited, we know that the vomit center is inhibited. I hope this concept is very clear, that low doses causes nausea and vomiting. High doses causes inhibition of vomiting. Now, opioid allergies. Yes, still physiologic effects. I know it's long, guys. Thank you for bearing with us. You guys are doing great. Let's keep writing and studying. Opioid allergy. Technically, it's very uncommon, right? But when it occurs, it usually acts like pruritus. Pruritus is technically just itching. That's pruritus right here. The skin adversities, because of itching and skin allergies, it's really not allergic reaction, but opioid pruritus can occur from histamine release, specifically for morphine and meperidine. The M&M will lead to skin adversities. And then opioid tolerance, which is after weeks due to high doses. Basically what the statement means is you will develop a tolerance to opioids. It will not affect you the same way if you do it for weeks and have higher doses given. So we become tolerant. Physical dependence, psychic dependence, and chemical dependence. Yes, opioids, we know they're narcotics. Our brains can become slaves to them. They can become heavy and lift us up and become dependent and have our lives go downhill suddenly, right? There are three types of dependencies. We got physical, which is after weeks of use due to continuous dose administration. If you do it every day consistently for weeks, we can develop physical dependence. What is that like? It means that opioids are needed to maintain regular bodily homeostasis. Our patients may suffer potential withdrawals when we get rid of this dependence. Psychic dependence? Not really associated with opioid consumption. It's just a behavioral syndrome when, we're craving the drugs. The patient is aware that there are bad effects that happen when this person is taking this drug, but they will still do it, and that's what we call addiction. Remember, just as a little revision note, addiction is treated by methadone. And chemical dependence, which is increased dose needed to attain the therapeutic effect, in other words, the tolerance, and no contraindications for opioids. They're just tolerated, they're chemically dependent on opioids. Let's talk about opioid contraindications. The significant chronic obstructive pulmonary disease, in other words, COPD. This is a strict contraindication of opioids. Emphysema and chronic bronchitis are the two diseases that you cannot give opioids in because of respiratory depression. It leads to suppression of breathing, and so does the emphysema and chronic bronchitis. So we don't want to add those together. In significant chronic kidney disease, we shouldn't be using opioids because our opioids will leave through kidneys themselves for excretion, and it will cause a lot more load than we need it to. When a person has chemical dependency, CNS depressant use, so if you're taking benzos or you're taking barbiturates, for example, we should not club them with opioids because they will just have an addition, a synergistic effect of depression, CNS depression. Acute hepatic disease. Remember in that motion picture earlier we saw that in the liver it causes hepatitis? Well, if you already have acute hepatic disease, why take opioids? And then comes the MAO inhibitor administration in concurrence with opioids. Now MAO inhibitor, right? MAO inhibitors. These are very important, and we will extensively talk about them in the coming slides because in the exams they do ask the relationship of MAO inhibitors and opioids. We'll take a look at these points in the future. And then shock or hypotension. We can't afford to keep depressing our CNS, hence CVS, hence entire body. We have to be very safe. When our body's already shutting down, we shouldn't be taking opioids. And of course, at the end, hypothyroidism. Again, we cannot afford to shut down our body. Now, moving on to one of the most important aspects of our lectures today, every drug broken down individually. So, get your pens and papers out again, guys. Let's run through summaries. First of all, morphine. General information, it is a natural opioid. We know that. Opioid or opium alkaloids is generally not used in regular dentistry. It does have a very high dependence as it's an agent that causes a lot more addiction than any other opioids. Ammonium chloride and morphine. Now, what does this ammonium chloride and morphine have in common? Well, ammonium chloride, when you take it with morphine, there is an increased urine excretion. Increased urine excretion of what? Of morphine. Therefore, consider this, that it prevents the reabsorption of morphine. So if you have a lot of morphine in your bloodstream right now, you want to get rid of it, then you have to take aluminum chloride. This will lead to increase in excretion. Okay? Let's talk about morphine absorption. It's low for oral, therefore we prefer IV and IM, intravascular or intravenous, and intramuscular. In distribution, the morphine will be distributed evenly into liver and fat tissues and just get stored there for future use. And then low blood-brain barrier causing, however, high placental barrier crossing. Now what does this mean? Blood-brain barrier and placenta. This has to do with pregnancy, of course. So, high placental crossing, therefore in pregnancy, your fetus can actually have the effects of morphine when you, as a mother, take the morphine. So, let's avoid morphine in pregnancy, shall we? Okay, and then in low blood-brain barrier crossing, this means that let's take a look at this picture. This is a normal blood vessel, right? Where there's the inside of the blood vessel, which is pores passing through, the lipid solubility substances passing through, and there are water-lined pores. So basically that's how our blood vessels and the contents within them will pass. However, in the blood-brain barrier vessels, we got the inside of the vessel, but lots of different protection. Not things will easily pass through, right? Only lipid-soluble substances can pass through. There are several tight junctions, therefore there are no pores that create the barrier, leading to lack of substances flowing out of blood vessels into the brain. If we need to, we must also have a carrier-mediated transport into the brain or a lipid-soluble substance being transported. The glial brain cells will support the entire barrier all along and making it into a fortress. Morphine cannot do as strong of an effect on the brain itself physically as the other drugs. So low blood-brain barrier crossing. Just a little concept for the future. Morphine. In metabolism, we have hepatic glucuronidation. It leads to an enzyme that is called UGT, which is a metabolic enzyme that leads to metabolism of morphine in the liver. It produces M3G and M6G as its metabolites. Now, what is M3G and M6G? It's morphine 3 glucuronide, morphine 6 glucuronide. Why are these two important? Well, they have opposite actions. So, morphine 3 glucuronide is a metabolite that has no analgesic effects. However, it causes excitation. So when morphine is converted through the liver into M3G, M6G, sorry, I'll erase that there. Remember, in the liver, morphine is converted into M3G and M6G. The M3G actually causes CNS excitation. We don't want that. What we want is what M6G does. It's an active metabolite. It leads to suppression, right? It causes CNS suppression. However, we also need to understand that it is 2 to 6 times more potent than morphine itself. So when it is metabolized through the liver, we get 2 types of results. Something very important to remember, guys. And then excreted as 1% unchanged. 99% of the metabolites get excreted, 90% in the urine, with 10% excretion in the feces. Remember, for all the other drugs, we will try and follow the same outline, of absorption, distribution, metabolism, and excretion. Okay, let's move on to the second natural analgesic, codeine. In general information, we know it's a natural analgesic. Its antitussive effect is prominent. Remember Benadryl from our childhood causes a weak agonistic effect, not as strong as morphine, therefore it is less potent as compared to morphine. In dosages, in adults, we have 60 milligrams 4 to 6 hours with a non-opioid combination. Guess what this means? This is Tylenol, guys, right? Non-opioid is acetaminophen and then opioid itself with a 60 milligram dose at 4 to 6 hours, right? This is going to be 300 milligrams. This is T4. Just a little revision from the NSAIDs. Now, pedo doses for children. It is 0.5 to 1 milligram per kilogram for the child. Same duration, 4 to 6 hours with non-opioids. In combination analgesic, we just talked about it, but let's take a little deeper dive. It is with a 300 milligram of aspirin and 30 milligram of codeine, or 325 milligram of acetaminophen with 4 levels of codeine. Same format, absorption, it is extremely high with oral as compared to IV, so we got 1.5 to 1 ratio for oral versus IV. The methoxy group is now replaced by hydroxyl group. Now methoxy group replaced by hydroxyl group, leading to the absorption of codeine in more oral sense than IV. Distribution, same thing, liver and fat. It's got a high blood-brain barrier crossing, unlike morphine. It's a high blood-brain barrier crossing, leading to high placental crossing as well, so let's avoid it in pregnancy. Metabolism, very important again. It is a hepatic, again in the liver, hepatic O demethylation with a CYP2D6. Codeine converts to morphine at metabolism stage, 10% of original. But this point is very important because CYP2D6 polymorphism can lead to either an excessive inhibition or no effect at all of the provided dose of morphine. What does this mean? Well, first of all, we know that our body has CYP families, right? Cytochrome P450, cytochrome 3A4, things like that. But codeine is metabolized in the liver by CYP2D6 enzyme. then it leads to the conversion into morphine. This is the essential of what we just talked about. But when a person is a victim of its polymorphism, CYP2D6 polymorphism, we don't know that if this enzyme will actually convert to morphine or will it not convert to morphine. But we'll take a look at the concept in the next slide in just a bit. In metabolism, there are no effects with drug inhibition such as serotonin reuptake inhibitors. In excretion, we know it's 90% through urine. Inactive metabolites will excrete prior to the active metabolites. So this is the concept that we were just talking about, that codeine will convert to morphine with the help of a liver enzyme known as CYP2D6, right? Liver enzyme CYP2D6 transforms codeine into morphine in the body. However, 1 in 12 people have a gene that causes the enzyme to be overactive. Therefore, children are less capable of metabolizing codeine, but too much morphine can slow down the respiratory function and lead to death. So this is a genetic condition, right? We got CYP2D6 polymorphism is a genetic condition. In 1 in 12 people, it causes enzyme to be overactive. Let's take a deeper dive into this entire concept. I know it's a little boring, guys, but very important for the exam, so thank you for staying with us. CYP2D6 polymorphism concept. FDA in 2017 warns that the use of codeine and tramadol as well in pedodontic patients and breastfeeding mothers. However, they're contraindicated in the treatment of pain in children below the age of 12. This is the genetic polymorphism concept. When the patient with this condition will metabolize codeine into morphine quickly, leading to severe opioid side effects, even at normal doses, right? 1 in 12 people will have overactive CYP2D6. Or the patients with this condition will metabolize codeine into morphine rather slowly, leading to increased requirement of doses to attain analgesia. So it will cause lack of pain inhibition. Therefore, we will need more doses to prevent pain. Okay, guys? That's what the polymorphism concept is. This is what the CYP2D6 looks like, just as an image so we visually learn. So as a summary, CYP2D6 causes codeine to turn into morphine normally, or it prevents the codeine to be converted into morphine. Okay, moving on, oxycodone. Remember, this is a synthetic derivative of the natural codeine. Oxycodone, codeine. It's known as Percodan when it is clubbed with aspirin. So aspirin and oxycodone is Percodan. The dosage are 325 milligrams of aspirin and 5 milligrams of codone. It is known as Percocet when it is mixed with acetaminophen. Acetaminophen plus oxycodone with 325 milligrams of acetaminophen, 2.5 or 5 milligrams of oxycodone. And last, this is only in the US and INBDE edition only, not for AFK, this point right here. It's when it is aspirin and oxycodone mixed together. We have 400 milligrams of aspirin with 5 milligrams of oxycodone. This is only for US, this combination, 400 milligrams and 5 milligrams. Hydromorphone is the next one. Remember, again, a synthetic derivative of morphine. Morphine. Known as Dilaudid in the market. It is pure hydromorphone hydrochloride. The dosage is 2 milligrams as 4 to 6 hours. Now, you'd notice that we kept talking about 60 milligram codeine and 20 milligrams of other drugs, but why 2? This just means that pure hydromorphone has a very high potency. So write this point down, guys. Hydromorphone is a very highly potent opioid. Hydrocodone, again, the synthetic derivatives, codone, known as Vicodin, sold in the States only, with acetaminophen and hydrocodone at 325 milligrams of acetaminophen with 5 milligrams of hydrocodone. And then Vicoprofen, as you can tell, US only, ibuprofen with hydrocodone. Dosage 200 milligrams of ibuprofen and 7.5 milligrams of hydrocodone. To remember this, guys, whoever's watched the series House MD, Dr. House was addicted to Vicodin in the States. That's hydrocodone, guys, hydrocodone. Next opioid is Tramadol. Tramadol has a Tramaset trade name. Acetaminophen with Tramadol. Remember, this drug was also contraindicated in children under the age of 12. So if they're children being treated for pain under the age of 12, we cannot give Tramadol because of the CYP2D6 polymorphism. And the dosage is 325 milligrams of acetaminophen with 37.5 milligrams of hydrocodone. Characteristics are partial agonist effect. Caution when using with MAOs. Remember, again, we kept talking about the MAOs here, the monoamine oxidase inhibitors. We'll talk about it in a little bit right here. And then methadone. Therapeutic usage, we got treatment of heroin and morphine. Addiction. Remember, AD, addiction. Methadone, addiction. Treatment of chronic pain. Characteristics, it's got increased blood-brain barrier crossing, so it affects the CNS very well. High protein binding capacity. High protein binding capacity at 90%, which means that it'll last longer than most other. See, remember that concept where a drug comes into the body and catches the albumin protein in the blood and then just travels along as inactive because albumin is keeping it busy. But as soon as this is broken and the drug comes back out into the blood, isolated from albumin, it will be active. Therefore, if methadone has a high protein binding capacity, then it will stick to albumin for a long time, and then albumin will let it go and causing its activity. Therefore, there is a longer duration. Therefore, T half-life is 15 to 40 hours. It also has a lower sedation than morphine. That's the characteristic. Metabolism is liver only, you guys. Okay, naloxone. With the O, you can guess here that we're talking about overdose treatment, diagnosis of physical dependence. Characteristics, we have highly metabolized in the first pass metabolism, so liver as always. High affinity towards mu receptors in the CNS again. 1 to 4 hours of antagonistic effects. Why antagonistic? Why is it a pure antagonist? Because we're treating overdose. We want to reduce the effects of opioids. And T half-life is 1 hour only. Metabolized in the liver. This is the naloxone kit that is offered by the government and private institutions to treat the overdose of naloxone in the hospitals. Therefore, we will see withdrawal symptoms while treating addicted and overdosed patients. Buprenorphine therapeutically treats dependence just like the one prior. This one has also treated chronic pain. Buprenorphine has less efficacy than morphine, therefore it's got less intrinsic activity than morphine, high affinity to mu receptors, and it's a partial agonist, so not too highly active, but still. It's appeared in a sublingual film, to be precise, for treating opioid dependence. Naltrexone is the next one. This is addiction, treatment of opioid addiction, and treatment of alcoholism. Alcoholism, AL. It's a little trick to remember. Then characteristics are long duration, 20 to 24 hours, and T half-life is 14 hours. That's pretty long, you guys. Side effects, dose dependent, so higher the dose, higher the side effects, and can cause liver cell injury like any other opioid. Nalbuphine, Therapeutic uses are moderate to severe pain or treatment of labor pain, preoperative analgesia, and supplemental surgical analgesia or anesthesia. Characteristics, we got agonist at kappa and antagonist at mu. So this is both, right? It's got a agonist and antagonist mixed property. At kappa, it is weak analgesic and sedative. In mu, it's an actual antagonist. Therefore, it inhibits morphine-induced analgesia and causes depressed respiration. How mixed is it? It causes all these different mixed feelings. This is mixed agonist and antagonist. Side effects, euphoria. Meperidine, this is a crucial drug, guys, so pay very, very keen attention to this. IV drug administration during treatment. We need to have IV drug administration during treatment, but oral drug administration after the treatment. Trade name, Demerol. Dosage in adults, we have 50 to 100 milligrams at 3 to 4 hours. In pediatric doses, it's 1.1 to 1.8 milligram per kilogram, 3 to 4 hours. In combination analgesics, we have safe with no interactions with aspirin and 50 milligrams of meperidine and acetaminophen with 50 milligrams of meperidine. Meperidine metabolism is very tricky because it first of all, it leads to hepatic hydrolysis as the mechanism of metabolism, then hepatic conjugation, and then metabolites are produced such as normeperidine. That leads to CNS stimulation. This is a problem, and we'll take a look at the contraindication for it in the next slide. If we want CNS depression as a function of opioids, then how come normeperidine causes CNS stimulant? It's completely opposite, right? So very dangerous. Adverse effects are seizures, tremors, muscular spasms due to CNS stimulation. That's right here. Coma and death are possible and also causes respiratory depression as one of its major side effects. Meiosis constriction and drug of abuse because of the effects that it has. Let's talk about meperidine along with MAO. What are the drug interactions of MAO inhibitors and meperidine? Well, meperidine, first of all, produces normeperidine, which is an active and a very dangerous metabolite of meperidine. We now know that it causes CNS stimulation, correct? Unfortunately, so do the MAOs. The monoamine oxidase inhibitors will also lead to CNS stimulation. How? While monoamine oxidase inhibitors will inhibit the reuptake of norepinephrine, dopamine, and serotonin, leaving them to be present in the synaptic cleft. Right? If norepinephrine, dopamine, and serotonin are left into the synaptic cleft, it increases the blood pressure by acting on the heart directly and increases the CNS stimulation by acting on the brain directly. Right? This we learned in the adrenergic system. And so does meperidine through normeperidine. Now, pentazocine. Therapeutic usage, treatment of acute and chronic pain, treatment of moderate and severe pain. Very basic. Characteristics are that it is as potent as codeine as its analgesic property is concerned. It can cause confusion and anxiety in the elderly patients, so very careful. It is a partial agonist at mu receptors. It is an antagonist at mu receptors. So now it's got a mixed behavior, right? Mixed behavior. And it's an agonist at kappa receptors as well. In dosages, we got 50 milligrams in pure form. When you combine it with aspirin, so say aspirin and 25 milligrams of pentazocine, we get Tolvin. That's the trade name. Duration is 4 to 6 hours. Propoxyphene has a therapeutic use of the same acute chronic pain, moderate to severe pain. Characteristics are less potent than codeine as analgesic property. So unlike the previous drug, pentazocine, which is as potent as codeine, propoxyphene is less potent than codeine. It is present in oral formulations. Here they are, the tablets. and they are partial agonists. So imagine this, if codeine itself is a weak agonist, and if propoxyphene is less potent than codeine, then of course it's a partial agonist. Its metabolite is known as norpropoxyphene, which is a CNS stimulant. Reminds us of normeperidine, therefore let's not club it with MAO inhibitors. The terrible MAOs. Now, opioid fentanyl. Now this is one of the most important drug of abuse in the United States. Treatment of severe pain, such as advanced cancer patients, are treated with fentanyl. Although it is a drug of abuse, characteristics are that it is 80 to 100 times more potent than regular morphine. Less potent as codeine when it compares to its analgesic property. Present in transdermal patches, lozenges, along with its IV formulations. The T-half-life is 2 to 4 hours when you give it as IV, and T-half-life is 13 to 22 hours when you give it as patches. IV administration for conscious sedation procedures. This we can use in dentistry. However, fentanyl is usually not the choice of drug for it. We usually like to use the benzos for conscious sedation. It's a partial agonist in its properties. A visual learner that I can't breathe, where fentanyl on its needle is weighing on the spinal cord and the brain of this patient. So, breathing problems, respiratory depression, coma, and death are the #1 side effects of fentanyl. Here's the fun one, loperamide. Therapeutic use, diarrhea. Remember, one of the physiologic effects of opioid is constipation. Well, what's the treatment of diarrhea? It's constipation, and that's where loperamide comes in. The characteristics is, for example, the Imodium is the trade name, agonist for mu receptors, but it doesn't have any blood-brain barrier capacity. No blood-brain barrier, so it doesn't enter the CNS the same way for pain as the other opioids. It treats diarrhea. Loperamide is definitely an opioid though. Even though it is non-analgesic, it's still an opioid. Antidiarrheal. Now, here's the most important slide for today, the doses for dental pain for various opioids. Now, these I have combined as a summary. Let's start with codeine. 60 milligrams Q4H, which is the regular dosage for all opioids, right? Q4H. Equipotent dose in IM is 120 milligrams. So basically your regular dose is 60 milligrams, IM is 120, and the same effect that you need is 200 milligrams for oral. What does equipotent mean? Equipotent means that to maintain the potency to be the same in different modes of drug administration, what dosage do we need? So for IM, if it's 120, then for oral we need 200. Keep this in mind that usually oral drug administration needs more amount of drug to give the same potency that intramuscular gives for less amount of dosage. Because oral has the whole GI tract to go through, the liver metabolism and so on, in order to touch the bloodstream first, right? While IM has more bioavailability directly into the blood with bypassing the biotransformation. Now, codeine has potency level at the lowest. Then comes oxycodone on the list. Dose is 5 to 10 milligrams. This instantly tells us that the potency has become high. Equipotent at 10 milligrams IM, but 30 milligrams oral. We need 3 times as much orally. Potency is high. Hydromorphone, even more potent. 2 to 4 milligrams is the dose. 1.5 milligrams for IM, equipotency at 7.5 milligrams for oral, and highest of the potency. And then comes meperidine, dose of 100 milligrams, which is even less potent as compared to codeine. Equipotent dose is 75 milligram for IM as compared to 300 milligrams for oral, causing it to have low potency. Pentazocine, 50 milligrams is the dose. 60 milligram needed for IV equipotency, and 180 for its equal counterpart in oral dosage. This is a medium potency, right in the middle. So just a few numbers to remember. They don't ask you doses this specific on the exam, but it's important to know which is more potent than the other. And this is a summary to remember that. That concludes our lecture for opioids today, you guys. The references are in the description box below. They're taken from Lippincott and our dental management textbook, Little and Fallis. Thank you for watching, and stay tuned for our new and updated lectures.